the what as well as the why for partnering with SAMHSA for this Bear Cares grant, specifically for the youngest of our population. And so we are, the City of San Antonio and the Head Start program, of which I work within the city, have children from ages 6 weeks through 5 years of age in our program. And we have over 3,200 children and their families. And we target, although that's probably not the word I should use just now, we select, how's that? We select children who are of greatest need. We truly look for and plan for having at least 10% of the children we serve to be children identified with disabilities. And we look for families that are at or right very close to the federal poverty guideline. So we're truly looking for the children and their families of greatest need. So when one does that, there are multiplicity of connected issues and problems with the families and with the children and with the institution. 100% of our children ages 3 to 5 are within public schools. Our young children, the infants and toddlers, are in 6 inner city child care centers. So you have some system pieces, you have some family pieces, you have some children needs. And what we've done differently with our SAMHSA partnership grant monies, well, the partnership's actually with CHCS, Center for Healthcare Services, is we've created an opportunity to address young children's mental wellness issues in the constellation of their family. Now previously, and those of y'all who know little kids well, and especially those in pre-K classrooms, realize that at a 3-year-old level, it's pretty hard to tell whether you're dealing with a behavior problem that's a function of the classroom, or you're dealing with a behavior problem that's a function of perhaps some other kinds of issues, because they look exactly the same when you're 3. So with our opportunity here, we've been able to truly institute a 3-tiered program of mental wellness for our children. Now this concept, the triangular concept of 3 levels, exists many, many places. That's really for us not the innovation itself. It's the ability to actually execute it has been the innovation. Previously, we really had no mechanism at a level 3 child, a child who is in desperate need of more than that, which can be handled in a classroom. We had no way to provide services for that child as well as the family at the same point in time. And y'all know as well as I do that you can't take a 3-year-old or a 4-year-old and treat them in their area of mental illness, perhaps, without the family. I mean, we're talking a system issue here within the family. And so this has allowed us to provide funds for the level 1 children in the public school classrooms, for the level 2 children by being able to take funds and provide behavior specialists who truly work with the teacher to make sure that the environment in which an acting out or a child with a behavior issue, we can make sure that the environmental factors for that behavior have been taken care of, and teach the teacher, show the environmental constructs that can be changed within the classroom. But then, when that doesn't really address or solve or give an environment where the child's behavior can be improved, because of our ability now to address level 3 issues with our partnership through the SAMHSA grant and CHCS, we can actually offer the family and the child the types of ongoing services that we've never been able to do before within the public school system. So it's been a bit of a rough start for the first year, in all honesty. When you're dealing with so many different sets of rules and so many different expectations. Head Start, for those of you who may or may not know it, is a highly structured, highly governed, standards-driven program. The public schools, which is 100% where our children are highly designed, highly governed, highly standard set of issues. And then we want to go outside of those two and provide mental wellness services to the entire family constellation because of a behavior issue or set of issues of a 3-year-old or a 4-year-old. So you have 3 distinctively different systems that the challenge is, how do we make that work easily, quickly, and readily available for families who may or may not have had successful experiences with any one of those 3 systems or all of them at one point in time. So the innovation for us, and I don't want to belabor this point, but is that ability to get the services together as quickly as we can, provide them to the family constellation if that's what's necessary, and provide that type of service to the child whose behavioral issues are of such magnitude that they cannot be addressed with changes in the public school classroom environment or what those issues that are under the control of the teacher, him or herself. We have referred about 8, the SAMHSA grant, let me go step back a minute. The SAMHSA grant is designed to receive 250 referrals a year. That's a lot of young children in need of intervention. Of that 250 referrals, which we did have this past year, about 18% of them come from the Head Start population in the inner city. The City of San Antonio Department of Human Services Head Start program serves children only in SAISD and Edgewood ISD. So we're truly just serving the young population. Excuse me. We're serving the population only in those 2 school districts. So that's the population that I'm talking about right now. So when we look at this intervention, even though it's only 18% of the 250 we refer, what we're going to be able to do is look long term and see if this truly does become the ability of young children being more likely to be successful when they get into kinder 1 and 2. That's the whole reason Head Start does what it does, is we want to prevent, by early intervention with the child and the family, those kinds of behaviors that can dictate unsuccessful experience in public school. We don't want that to happen for our children. So now we think we have a model and a partnership because of the SAMHSA funds and putting young children directly into that system of care. It isn't that it wasn't available before, but it was not a focus. The younger the child, the greater the probability that the intervention will make a significant difference in how they are able to be successful in a public school arena. It becomes the least restrictive environment for our children. It becomes a pathway to their learning. It's, in all honesty, it's just a lot more fun to be in a classroom when you can comport yourself in a way that you are able to learn and to be there and not be pulled out of class because your behaviors are unacceptable or for whatever reason. And so this is going to take a while. This is not a silver bullet. We're not going to fix every problem for every young child who has an issue that requires tier 3 or level 3 intervention. But I think if we as a community begin to look at these kinds of partnerships across time, we will begin to see the difference in our 2 school districts where we concentrate our efforts. And what can I say in closing is that's our goal. We want our 3,236 kids to land in kindergarten and first grade in the 2 school districts ready to rock and roll, ready for their parents to know what the expectations are and that they have received the kinds of support that they needed to get that 5-year-old or that 6-year-old where they need to be so they can experience school in a very good way. It's a truism that success breeds success in public school. Little kids who are successful in elementary school become more likely middle schoolers who are successful. And if you can get through middle school successfully, you're going to be fine in high school, okay? So that's our whole idea behind our SAMHSA grant and our partnership with CHCS. So now it's my pleasure to ask a parent. And she is, I believe I get this correct, she's the chairman of the governing committee for our SAMHSA grant and for the systems of care, and comes at this from a parent's perspective. So here you go.
Thanks, Barbara. So my name is Shanna Wheeler. I got involved because I'm a mom. I'm not a professional teacher. I'm not a professional anything except for a professional mom, I think, at this point. I got involved because I have 10 children. I have adopted 8 children through the foster care system and have been a foster parent for the last 13 years. So I've been around a little bit, and we've fostered over 45 children in that time. All of my children that I currently have in my home that are adopted, the 8 children, all have mental health issues, ranging from schizophrenia to ADHD to autism to all different kinds of fun adventures we have in our home. And so through that process, I kind of learned different things in the system maybe that were wonderful or things that I really didn't have access to and couldn't find. And so in experiencing all these things for myself, decided that I really needed to start advocating for things that I saw. As I became more involved in foster parenting, I became a behavior management trainer and started training other foster families and different kinship families that were having some mental health challenges with their children and started going into those homes. So through that process and kind of meeting all the families and working with them, I've been able to see the system from all different kinds, from all different sides, from all different perspectives with all the different abilities and challenges that we have in our home. That being said, I am really, really excited and looking forward to the wonderful things that I think that the Bear Cares grant, or the SAMHSA grant and the Bear Cares Foundation has, that's going to be available in our community and is available now. Barbara mentioned that she is one of the partners that CHCS has and the City of San Antonio has on the grant. Currently, right now, the grant has been around for a little while. The first year was a little bit slow. I'm fairly new to the council and just came on in last May. So it's been kind of a new thing, and the CHCS and Bear Cares is moving kind of in a new direction right now. And we're really looking forward to all the possibilities. Right now, Bear Cares is really looking for partners. It's a community effort. Head Start is one of those partners, and through that Head Start program, Barbara's talked a little bit about how now that Bear Cares is able to, CHCS is able to send partners into those homes to work specifically with families. SAMHSA is a family-driven grant. It's supposed to be very family involved. And as you all know, as much work as we do in the schools, as much work as we do at providers' offices, if those needs aren't being met in the home, then we're not going to be as successful. And so that is a huge part of the SAMHSA grant, is to be very family-driven. That being said, right now on our board and who we're currently working with is the Department of Family and Protective Services. We're also working with different joint collaborations with the military, bringing in kinship partners with Voices for Children. Many different agencies are a part of this program. I think what our potential and what we would really like to see happen with Bear Cares is Bear Cares becomes the one-stop shop for children ages 3 through 8 who have a mental health diagnosis or think that there might be some mental health care challenges where there needs to be some intervention. Either that intervention happens in the school system and we provide training to the schools, that intervention can happen with providers, that intervention can happen with families at every aspect and every level so that there's help for families. just to kind of give you a little background with our little guys, I have a 4-year-old son who, well, he's not 4 now. We got him when he was 4 years old. He was found living feral at the age of 4 here in a local county and had been living on his own since he was 1 year old in the woods. And as you can imagine with our little guy, we've had a few challenges, and he is learning how to live among people. Is really our big thing. And as we've tried to navigate the system for him, we've navigated through school systems and trying to train and help schools come along and learn how to help him in school. We've worked with providers. He's been through the mental health core system and court committed. He's been through different hospitals and different residential treatments, and he's now back home and doing really, really well. We've gone through that process and we've had so much help with him. But what's amazing to me is it's been a community effort. He's had occupational therapists and a teacher who came and helped us move. What teacher does that? You know, we have had some wonderful, wonderful doctors and therapists and professionals that have helped us so much along the way. That is our goal here at Bear Cares, is to provide families and these children specifically with resources in our very rich community to be able to have that one-stop shop so families aren't having to go to 10 different locations to try to get help. When you have a child in crisis, or maybe not in crisis, but you're just desperate for help, it's really hard to shop around. It's really hard when you're having financial problems for some of our low-income families. Maybe it's a cultural challenge where we don't speak the language and we're not able to get access to services. But to have that one place that we can go to look for, that will be the help that we need to navigate a system. That is the goal of Bear Cares. That is what we are looking for partners for. We have many plans in the work to work with many different families, and to also not have the only entry point being Head Start, but having entry points within the school system. In different school districts. We have several different school districts that we're currently working with, to work with the military effort, to also look at the Department of Family Services. We're also looking with post-adoption services, all those different programs and resources so that any child in our community who is suffering from a mental health challenge, or the family is suffering from challenges where they need access to those services, that we'll be able to be that and provide that. And I'm really hopeful and looking forward to the many things that I think that are to come with Bear Cares.
Hello, everyone. I'm Judge Daphne Previty Austin, and I'm here with Jeannie Von Stoltz. We work with juveniles, which are kids between the ages of 10 and 16 that have committed a crime. And we're working real hard to try and get those kids out of the criminal system and into the mental health system. Because a lot of kids have, they'll have some kind of an outburst or some kind of a situation where it's their mental illness that might be contributing to the reason that they committed their crime. And those kids really don't need to be in the criminal system with the other criminals. It would be great if we could get them diverted, get them into treatment, and have them learn the triggers and things that might set them off, and be able to learn what they need to do as they grow for the whole rest of their lives. If they have something that's triggering an issue, that they can get the treatment they need and not just be in the mental health system. So I commend Michael and Shanna for working with the really babies and the younger ones from, I guess, up till 5 and up till 8. And then once they get to be 10, we find, for example, there might be a child who's having a lot of issues at a school, and the school's really exhausted all their resources, and they can't wait until the child turns 10, because then when they push another child in class, or they are having an episode and they're being restrained and they flail and they hit the teacher, they can be sent to court. And for those of you that don't know, if you hit your teacher, that's a felony. And so it's really a big deal for a 10-year-old to be struggling with a mental illness, but then also be in the criminal system and be facing a felony and possibly a conviction that can stay with them for the whole rest of their lives. We've had some situations over the years. Our juvenile court systems have been here for many years. We have one great Judge Parker, Laura Parker, who's our more senior juvenile judge, and she has now a girls' mental health court that's probably been around for close to 8 years. Before I was I'm a new judge. I'm the low judge on the totem pole. So before I was a judge, I was a prosecutor for more than 10 years here in Bexar County. I had my own defense law firm for about 8 years. And so I would see kids that would really need a special situation, and they would be a boy, and we just didn't have anything. And so we've had the girls' court, and one of the things I really wanted to implement during my term was to get something going for the boys. So I'm very pleased to announce that we got a grant. Okay, thanks. We got a grant from, well, the very first grant we applied for, we received. And so I feel like we're blessed to have gotten it. And so our girls' court is called the Crossroads Court. And the court grant that we applied for really wasn't meant for a boys' mental health court. Nationally, there's this idea, and we've been seeing it recently, even this week in the news. Sometimes there's somebody that's having a mental health episode and may get shot by a police officer because the police officers don't have the proper training to know how to de-escalate those situations. They may be fearful, and sometimes they shoot to protect themselves first when maybe that could have been de-escalated. So the focus of all this grant money really was for that kind of training. They saw that there's a need for that nationally. And so, you know, whenever you apply for a grant, the people that apply are the ones that have the opportunity to get the money. And so I think we really just got very lucky that our proposal was met. We're being supervised by the Council of State Governments, and we received the grant. I took the bench on January 1st of 2015, and we received the grant toward the end of last summer. We applied for it early on, and the grant itself started, thanks. The grant itself started October 1st of last year. So this is the last day of our first year, which was supposed to be a planning year, and then we have 2 years of implementation. I've been very aggressive in trying to get it started sooner, so we've actually already had some court meetings and staffings and identified the children for the program. So we have one in September that we've gotten in, and we're going to be staffing 3 or 4 more at our staffing next week, and hopefully trying to get it up. The maximum amount of children that we can serve at one time is going to be 12. And we're hoping that within a period of about 6 months, we can get them stabilized, learn what kind of community partners we can get them in touch with, and that we can move them out of the program and into, they'll get their record sealed, but they'll just be in a perpetual maintenance type of system where they know what they need to do should they need something. So studies show that 1 in 5 children suffer from some form of mental illness. But of those, only 1 of those 5 would receive treatment. There's a lot of children that are undiagnosed. I've been doing some work with the Clarity Mental Health Hospital and learned things from them, and one of those is that a lot of the children don't even realize that they have a mental illness until they're arrested for the first time. We do some intake screens at the detention center that will help them determine. Usually the first thing really is this a child that might be suicidal or some really high-risk type of behavior that we need to know about right away and get them in treatment. But then based on those screens, we figure out which children might be best diverted into either the Crossroads or the Boys Court, which is called MIND. It stands for Males in Need of Direction. And then the National Conference of State Legislatures have determined that 60 to 70% of the children that are arrested each year have some form of mental health disorder, and 25% of those can suffer from a severe mental illness. The grant, talked a little bit about this already, the grant that we received. There were 16 communities awarded that totaled $4 million. Our grant was just a few dollars short of about $250,000. And the partners for this are donating a lot of their time. So for example, I'm a full-time judge. I've tried to make my docket super efficient to be able to carve out a few hours a week to donate my time to the grant. So the grant's not paying part of my salary. The probation officers have a set number of probation officers, and they've also retooled their team to be able to dedicate a probation officer to this court. And so the reason there's only 12 at a time is that one probation officer needs to be the one that handles all 12 of those cases. And if you can imagine how severe the needs might be and the amount of time, contacts that they would need, it's really helpful to have that one person handling it. And so we actually just selected that person in the past few weeks. He's a young man, probation officer, so we're hoping that he'll have a dual purpose of being also maybe a mentor to some of these boys. And then our grant, we were one of only 2 grants of the whole country that applied to juveniles. The other one was I don't know the correct term, Native American Indian grant. So hopefully that definition didn't offend anybody. So in the planning process, we really had a lot of help from a lot of different partners. We created a community task force. We met once a month, the 3rd Wednesday of each month, for probably about an hour and a half to 2 hours, trying to just hash out, we're the first mental health boys court in the country. So all the community partners were trying to figure out what would be really helpful to these kids, what would be unique characteristics. We didn't want it to just be the same exact program that we have for the girls, but put boys in. We wanted to try and develop it so that whatever the boys' needs were, we might be able to meet those. So some of the partners, I think, are on a future slide. Let's see. Okay, so there's people from the court. Also, the DA's office is donating the time of their assistant district attorney that's going to be working with the court. We have the consulting psychologists. There's a defense attorney that is working with the court. The local mental health authority, the Center for Healthcare Services went with us to the training last year. In December, we went up to Washington, D.C. Child Protective Services was involved. Some of the children's mental health agencies, we had a representative from Jewish Family Services, from the Clarity Children's Center, some educational agencies. We had people from communities and schools, and of course, juvenile probation. And then we had one gentleman, Dr. Tom Stone, for those of you that may know him, that kind of was our overseer to try to keep everybody together, in focus so that we could achieve a lot during these hour-and-a-half meetings each month. So we wanted to define or refine the target population, and the grant applies to all the kids in the jurisdiction of the court, which right now are 10 to 16 years old. We might try and focus it down to like 11 to 14-year-olds to get started, just so that if we have a 10-year-old and a 16 or 17-year-old in the same outing, they might have more in common if they're closer in age. So we're going to see how that works out. We've identified a lot of evidence-based services and supports. We've done a lot of research on what types of programs and training are out there for boys. And then we did a request for proposal. And the group that got awarded the grant from, so most of the $250,000 is going to the treatment provider, and it's going to be a group called Southwest Key. And so they are going to provide 3 staff people, a clinician, a caseworker, and then a family liaison to work with the families. The family liaison position is only a half-time position, but they're up, they're hired, they're started, and they're going forward. And so we're all real excited about it. And so then, of course, since the program only has 2 years to really live and breathe under the grant, we need to get it to where it's self-sustainable, and that's what the sustainability is. So our mission statement, one of our meetings we spent defining that, is to end involvement in the juvenile justice system for boys with mental health needs through a comprehensive family and community response. And basically, one thing I saw for many years as a prosecutor was there'd be people suffering with a mental illness, and you might see them panhandling at the Valero. and then you see, or at the bus stop, and then you see them get arrested for criminal trespass or panhandling, and they'd go to the jail, and they might sit there for 3 weeks or 4 weeks until their case came up on a docket, and then they'd get released from jail, time served, but would never get any treatment. And so it's just this endless cycle of those unfortunate souls not getting the help that they need. And so one of our goals is to stop that revolving door of the continual arrest. Okay, the criteria for being in this court, we have several different specialty courts. We have, like I mentioned, the girls' mental health court. We have there's 3 full-time district courts, and we all have a full-time associate judge. So all of the courts have a pre-adjudication drug court for kids that are kind of dabbling in drugs for the first time, trying to get them, these are diversion programs, so they have not actually been adjudicated, or that's a word that would be considered a conviction in adult court. They haven't actually been found to have committed their offense. It's kind of like if you do this program, it's a get out of jail free type of deal. You do the work, and you work real hard, and you get stable, and you get the opportunity to not go to court. If you don't do well in the program, you get referred back to court, and you would be a regular type of case that gets supervised by the community supervision department. So to be in this court, we also have a couple other courts. We have a court for family violence, and then we have another court for girls and boys, but there are mostly girl participants involved in it that are victims of human trafficking. We call that Restore, to restore the dignity to these young girls that really are involved in the trafficking. So for the mental health, most of the offenses need to be nonviolent, but like I mentioned, there's these hitting the teacher, hitting a sibling cases. We'll take those, but they can't be aggravated violent cases. The risk levels, we have so many different programs available through probation. We're trying to really reach the moderate risk level because we think we could do the most good. If we had the kids that are low level, they might just do well with extra services at home, in the community, not being supervised by the caseworker, the counselor, and the probation officer. They might be able to just go to the probation officer once a month for 3 months and kind of get back on track. If there's academic issues, we want there to be an involved family member because these are intensive. They have to have maybe as many as 4 contacts with the team a week at the beginning. Then, it'll taper down. They come to court at least once every 2 weeks. I'm meeting the first and third Thursdays of each month in the afternoon. And so they need to come and they need to tell me what they've done to improve things from the last time they were there. So we're giving them a little sheet where they can make 3 goals for this week, and when they come up to the bench and I kind of check in with them and visit with them in a progress report type of style, I want to know, whatever their goals were, did you meet them? Do we need to work on one of these again next 2 weeks? So we decided to take for sure all the first-time offenders. They have to be eligible for the deferred prosecution program because the DA's office is involved as one of the partners. But we're also considering first-time failures. There might be a kid who's come through the court system before, but we didn't know that time because they had such a casual interaction. We didn't recognize that they had a mental health issue. So those are ones that we're also still taking. We're excluding the ones that have psychosis, intellectual and developmental disabilities, solely a conduct or disorder, or ODD, oppositional defiant disorder, or severe substance abuse. And we have another specialty court for the kids that are using hardcore drugs. It's the post-adjudication drug court. And they're the ones that are using a lot of drugs, a lot of heavy drugs, and we're trying to get them stabilized as well. So we have these smaller work groups that did the proposed programming components. The task force identified some of it, and then after Southwest Key was identified, we've been having a lot of really intensive meetings since July with that specific team to try and get everything going. It's still in the very early stages. We had only a couple of staffing so far. The first one with a child that's actually coming through the court is going to be next Thursday. So let's see. Each time when we meet, we'll have a staffing meeting. right before court. All the kids that have been identified as being potential candidates, we want to make sure that the family is really interested in being involved. Sometimes a kid might be a great candidate, but there's not an interested family member that's willing to put in the work and get them here, there, and everywhere to make sure that they can succeed. And sometimes the additional issue we find is that the parent may also have a mental health issue, and that makes it hard for them to comprehend how great of a program this could be for their child. So as we identify them, they agree to do it, then we have our psychologists do a battery of tests to make sure that they really are the appropriate candidate and help us put together the treatment plan before they come to the staffing. So we get all those reports at the staffing meeting, and then the team would decide if we were going to go ahead and admit them or not. And then if we do, they sign a contract, and they would start coming in every couple of weeks. So they have a lot of contacts. Again, each week they'd be meeting with their counselor, their caseworker, their treatment provider. We have, many people don't know this, we have a lot of probation officers assigned to various schools, and the ones that don't have a probation officer at the school, we have contacts where we can get a lot of the records. We can keep track of their school records and their attendance and things as well. So, and we're going to be making contacts with them at their homes to help with the transportation issues. So there's going to be the home base, the case management, there'll be individual and family therapy. We have separate parent training courses, and then group therapy and life skills training, and there'll be a lot of outings and things with the kids too. And then we have some incentives that we'll give them when they're doing well or they move up into the next system. And as they're doing really well, we'll taper off the contacts. We'll start real intensive at the beginning, and then we'll taper things off as they're doing well. So I thank you all for your time. I'm glad that all of you take an interest in the kids, and I thank everyone here for the work that you do.
Thank you, Judge. Okay, so while I'm switching over the PowerPoints, everyone, I want you to take your hands and rub them together, and maybe we can heat up this room, or at least ourselves. What do you think? Will that work? Is it working for anybody besides? I need it warm. I'm not feeling the breeze over here. Is anyone else cold besides me? Okay. Oh, it's not their fault. Okay, so I get to talk to you about the big sister of the Mind Court, which is the Girls Mental Health Court. And that's a court that's been in effect since 2009, and I guess it was the precursor to the Mind Court. And so just a little bit about specialty courts in general. The idea behind a specialty court is that it's a different way of approaching those that are struggling in either the criminal or juvenile justice system. Instead of an offender going before the judge only when they're in trouble, right, when they've made a mistake. The idea behind a specialty court is that the court gets to develop a relationship with the offender, which I'm going to switch now to calling a child, because that's what we're working with. So the child gets to develop a relationship with, basically authority, where the child regularly goes before the judge, and the family does, but the focus is not on what mistakes have you made, but how are you doing in addressing whatever specialty issue is going on? How are you doing in addressing your mental health issues? How's it going in addressing, like we said, we have girls that are involved in trafficking. And what can the court do? What can we as a community do to support you? So it's really about, like you were talking about, bringing very different communities and agencies together to support that child and that family. And so what we see a lot is it means so much. I mean, I, as a psychologist or even as a probation officer, can talk to a kid and family and go, you guys have been making so much progress, we're so proud of you. But to have a judge do that, to have a judge checking in with someone and saying, how's it going? Wow, that's great that you're doing that. How are you struggling this way? Well, here I want you to think about this. I want you to work on that. It takes it to a whole nother level in regards to the intervention. It makes that child and that family feel the support that is really there. It just helps them kind of understand that. Does that make sense to everybody? And so some of you may be going, well, why do we do this? And what the judge had mentioned it briefly, is what we are seeing in our system now is about 30 to 50% of our kids walk in our door with mental health issues. Even though it's 1 in 5 in the general community, it's 30 to 50%. And that number ranges, in regards to the more deeply involved kids, we see higher rates of mental illness. And what I'm concerned about, and what we're all concerned about, is that the criminal and juvenile justice systems are turning into the mental health providers of this jurisdiction in the country, right? And that's the last thing we want. We do not want to be the mental health provider. I do not want a child who has mental illness to be with and around a child who we call a high-risk child who's at high risk for criminal behavior. I don't want a mental health child to learn those types of behaviors. It never goes the other way, right? It never goes where the gangster learns how to, have, ADHD. It's always the ADHD the kid learns how to have kind of, gangster or drug-related behavior. So that's what we're trying to kind of do. What we also see in our system is that we see children with incredibly high rates of trauma. And you guys are probably all familiar with the ACEs study. I mean, our kids on average, and I think what you're doing is really trying to focus on addressing those with the child and the family early on. Our kids on average have at least 4 to 5 instances of trauma. And so they have high rates of trauma, which not only affects mental health issues, but it affects their physical health. It affects really their longevity, their lifespan, in regards to how long they're going to live. So we're kind of working with those factors. Okay. So why did we have a girls' mental health court way back when? So this is in 2008, 2009, and what we were seeing is when we were looking at our data, which is always a valuable thing to do, we were seeing that we had a lot of girls being ordered into residential placement, disproportionately. Even though at that time our girls were maybe 1/4 of our juvenile justice system, they were half and even more than half of the kids going to placement, right? And then when we dug down a little bit deeper, not only were these girls taking up going to placement a lot, but they were also like really low-risk offenders. I mean, they were going when they committed their first crime or maybe even their second crime, where we tend to do everything we can in the community for a child, and so by the time they get removed from the home, they've, committed, not crimes, but they've been back before the judge 4 to 5 times. Oftentimes when a kid goes back, it's not because they've stolen again, but because now they've failed to follow the rules of the court. They've failed to follow the conditions of probation like curfew or getting, doing good in school. So, but anyway, these girls were like first timers and they were going. And we were like, well, what's going on with that? And so what we also found is that, okay, so we're taking these girls at high rates that are very low time offenders, and when they come back, they were recidivating or reoffending at a much higher rates than the boys were. So we were taking them out of the home, and we weren't doing any good, right? They were still getting in trouble. And so we kind of dug a little bit deeper, and we started kind of having focus groups. And the funny part is that our probation officers would literally say, I will take 10 boys if you just take this one girl off my caseload. I mean, they did not want to work with these girls. They said they drove us crazy, there's too much drama, we don't know what to do, it's constant all the time. 10 to 1, I mean, that's a huge trade. I mean, if you've ever met our juvenile justice boys, a 10 to 1 trade, I don't know if it's ever, but they were willing to do it. So, so we kind of dug down and kind of figured out, well, what can we do with these girls? And what we found is that a lot of these girls struggle with significant mental health issues. Bipolar disorder was a typical diagnosis, PTSD was a typical diagnosis, and really high rates of trauma. So our target population is similar, 12 to 17 years of age. Ideally, we'd wanted it to be 12 to 15, but everyone kept saying, well, what about this one? What about that one? And so it's really kind of broadened over time. They have, obviously, like I said, the mental health issues and the trauma. What we began doing, like I said, with the mental health court model was the way that it works, just so that you know, is a child is identified, typically through some formal psychological assessment. The team reviews the case to say, is this child appropriate? And when we talk about things like psychosis or oppositional not being included, it's if either like for psychotic, if the child is severely psychotic. If they're actively, floridly psychotic, they need kind of more inpatient care, and then we look at transitioning them into the mental health court afterwards. If they're solely oppositional defiant, that's more of a criminogenic issue, so we don't want them around our kids that are truly mental illness. So that's what we're talking about in regards to exclusionary criteria. So, but we review those cases, they say, yes, this child's appropriate for court, and then the idea is to really drive the services around kind of the child's and family's needs. Oftentimes you'll see that these courts are often really intensive on the front end to engage the child and the family. They meet with them frequently. The providers will often be in the home two times a week. The probation officer will be there equally as often. These programs require 24/7 availability by both the clinicians and the probation officer, because the families often don't know how to respond in a crisis. And what they've been doing is when they have an issue, you're nodding, and at home, the first thing they do is they call the police, because the police becomes kind of the de facto parent in a way. And so it's really kind of training them what's a parenting issue, what's a physical crisis, what's a criminal crisis, kind of helping them kind of figure out what to go depending on the crisis. So they learn kind of these skills. And then as the court progresses and the child progresses through treatment stages, then the intensity decreases. And so the idea is to jump in, stabilize the child and family, and then really get them connected to those long-term informal and formal supports. Because the idea is not for the court to be involved more than 6 months, maybe a year, depending on the issue, but for them to have the services that they need and not have to rely on the juvenile justice system to get those for the rest of their life. So again, the services obviously tend to be home-based. We try to eliminate all barriers, right, all obstacles to obtaining treatment. Oftentimes, if the family has been trying to address the child's mental health issues, they haven't been able to get to the treatment provider consistently. Transportation, availability in regards to where it's located in town, hours of operation, all of those things have created a challenge. So it's really home-based services at first. A lot of parent training involved. With our girls, what we tend to see is kind of more family relational issues, lots of challenges between mom and daughter. And with the boys, we're probably going to see a very different kind of mental health presentation. It's probably going to be more externalizing type behaviors. And then the appeal for all these courts is that at the end, it's automatic sealing. The child doesn't have to hire an attorney and know all the political or legal steps to take to close a record. And it's not, they don't even have to initiate it. We do that. We give them a few months to make sure that they're doing okay. If they don't reoffend, then we seal the records automatically. And so then they can move on with their lives and not have to worry about it. So what we realized as we began working with the girls is, oh wait, we need more than mental health services, right? Guess what the #1 service that we needed was? It's at the top of the list. So we start this court, and I don't know, about 3 weeks into the court, our 12-year-old is pregnant, right? So we're like, okay, here's another. So now that almost takes priority over the mental health issue in regards to, when we're doing the psychological evaluation, really quickly exploring, okay, are you sexually active? Are you taking birth control? And then really working with our community partners to kind of help them get connected to true health clinics, not just family planning clinics, but health clinics for the child to address kind of their entire reproductive and physical health. Okay, we also learned that we kind of really needed to add a lot of school-based crisis intervention, which is where we got partnered with communities and schools. Because having communities and schools or having a relationship with that school counselor or whoever wants to be the identified support, because not every campus is a communities and schools campus. If there is just someone on that campus that wants to be that voice for that child on that campus. We've seen coaches, we've seen band directors, we've seen ROTC directors, everybody. It doesn't have to be your traditional school administrator. Whoever wants to be that liaison and the eyes on that child is so beneficial, just for that child to know that they're always supported. They'll joke and say always watched at some points, but they complain about it, but then they also miss it at the same time, right? So it's just like, your own kids. Why are you always checking on me? And then the first time you don't, then they're like, where were you? So it's this kind of same thing. We also stress the importance of recreational activities. We get these girls, and we will do the same thing with these boys, get them connected to activities they've never seen before. And activities that they love. We go to things like movies, but we also go on college tours. We go on museum tours. They've gone to, those painting ceramic classes. They've done equine therapy. They've done the experiential learning, the ropes courses, just to kind of expose them. And we've had girls say, this is something I really want to do. We've even hooked up a girl to a boxing class. And I have mixed feelings about that, given that I'm a psychologist and all the brain stuff that I think about. But for her, that was really powerful. It helped give her kind of strength and courage in a way, and she felt like she could accomplish things, and it really also was a great way to kind of relieve stress for her. So we try to kind of involve all of that. The biggest challenge for probably any of you that are working with someone who's got mental health issues is how to connect them to psychiatric treatment. the access to a psychiatrist. And a lot of that requires just, pre-planning and having backup plans all along in regards to, okay, she does need to see a psychiatrist, let's get her an appointment. That appointment is what, 2.5, 3 months away if we're lucky. So what do we do until then? And know that we have good relationships with the psychiatric inpatient facilities in town if it really reaches a crisis level, but we don't want to hospitalize her just to get a psychiatric assessment, right? So trying to walk that and navigate that. But that kind of knowledge requires a group. I mean, this is a district attorney going, okay, we know she's acting up in school, but we're not going to immediately pull her and yank her and lock her back up because we know we're working on it and we see progress. This is the defense attorney saying, having a child watch 24/7 is not always great because everyone's going to screw up at times, excuse my language, but everyone's going to mess up at times. But I trust that you're not going to immediately file on her just because she's messing up. So, what can we do to all support this child and get along as different agencies and entities? This is the partners for our program. Similar to Judge Privity Austin, we have Judge Laura Parker as a 386 District Court Judge. She leads it. Defense attorneys, treatment providers, district attorneys. We have someone doing psychological assessments. And as I mentioned, we have our internal mentoring program, our internal CHAPS program, all kind of dedicating time to this program. The key is the 3 or 4 that work with them frequently, the probation officer. You have to have kind of a special personality. I mean, I know it's only 12 kids at a time, but it's 12. I mean, and these are people that are calling you at 3 a.m. Sometimes the parents are calling at 3 a.m. because he didn't wash the dishes today. And helping them work through, okay, is that a crisis? What can we do? How can we not escalate it to where he takes off or bashes a hole in the wall, but he still gets an adequate consequence for that, kind of helping them balance that. So I thought, we've highlighted kind of the specialty courts. I did want you to see outcomes for programs like this. I think that's really important. So understand that these numbers aren't huge, right? And this is relatively inexpensive program, but it's nothing compared to how much it costs to send a girl to residential treatment and the loss and the separation when she's taking out of her home. So to date, and this is since 2009 really, we've worked with only 108 girls, but it's 108 girls. And I'm going to say 63% successfully completed, but I want you to kind of notice something because we have really high expectations in regards to graduation from a court. But what we have seen is that even for those that didn't graduate, there was benefits that they gained from the program. So of the 63 that successfully completed, only two kids wound up going to residential placement. No, of the 63. But out of the 108, 82% didn't reoffend within 3 years. So out of the 108, even those that did not graduate, we had over an 80% non-reoffend rate. And for us, I mean, that's kind of what a criminal justice system, I mean, we definitely want good outcomes. We want them to be happy, positive, productive citizens. But, really, we don't want them to break the law, right? That's kind of what we're funded for. And over 80% of these girls did not break the law after completing, even if they didn't complete the program successfully. But what sustains this program is that we keep preventing girls from getting sent to residential placement. Even though this is an expensive program, it is still much cheaper than locking. So 63% would be 68 of those girls. Wow, and you don't even have a pen and a pencil. Oh, okay. Is that really a calculator, or is that the hidden thing that gets you to those apps that we don't want you to know about? Okay, so 68% out of the 68 girls that completed, only 2 wound up in residential placement, which earlier, all 68 would have gone to residential placement. So that's what we call a huge savings. And we expect to see the same with the boys in regards to lower recidivism, less use of kind of county funds in regards to those high-end kind of placements. And none were committed to TJJD. I don't know if you guys know what TJJD is. For those that don't, it's the teen prison system. So there's a teen juvenile justice or juvenile probation system, and then even at a higher level, the teen prison system. And so for this is since the inception of the program. So there are some girls that have been through the program and done since 2009, and this is still the numbers as today. Okay, so we have time for questions for any of the panel members. Is that correct?
And maybe I'll do a couple of quick things for you guys. CEU sign-ins are sort of being passed around, so if you need a formal CEU, be sure to do that before you leave the session. They're back there with Amy. She's raising it up. It's got a red cover. Thanks. Oh boy, now I just totally forgot the other thing I was going to say, and that's all right. Anyway, yes, we can talk for a little bit, have some questions, and I'll try to help watch and see who has a question. Yes, right back there. Talk loud. If we can't hear you, I'll run back there.
My name's John Meyer, and this question is for Dr. Stoltz and Judge Brady primarily. I co-chair a work group for the Texas Office for the Prevention of Developmental Disabilities. Our primary focus is fetal alcohol spectrum disorder. There's some anecdotal information that shows that there's a probability of a large percentage of children, both in the foster care system and in the juvenile court system, to have FASD. And I just wondered if you considered that, and if not, if you would, because it's, those behaviors can mask lots of things. But that's probably a very prevalent issue in this population. And there aren't very many people I know that are experienced in screening and evaluating them. It would be probably really a critical and could be an important piece of what you're doing. So I just thought I would mention that and see what your response would be.
Jeannie has a better understanding of all the psychological background things. I have the more criminal experience, but I don't want to say that we would exclude anything, but it's my layperson's understanding that they generally have a lower IQ. Is that correct or no?
Not with the syndrome. It used to be with FAS when it was truly fetal alcohol. Yeah, now it's a spectrum.
Really are reflected in lots of kinds of behavior, but not necessarily low IQ.
So, yes, anybody that has an identifiable mental health disorder, and I believe that would fall within that because it's in the DSM, right? That we would consider taking them as long as they met all the other criteria with the involved parent. I wouldn't want to have somebody that had such a low IQ that they wouldn't be able to be successful in the program. We want them to have the ability to learn and go forward.
So that's not necessarily the case, right? So just if there could be, it could be so prevalent, it would be worth highlighting that as something that's just, you probably have a battery of screenings, and that would be considered as part of that. That's kind of what I'm advocating for.
Thank you for bringing that to our attention. Would you like to add anything?
No, and I think, because we do a formal psychological assessment at the time of considering whether they're appropriate, and that's something that I can ask. The forensic assessment, I mean, they're more forensically trained in regards to, but they do the full, it's all screenings, right? This is not, so they do an IQ screening, an academic screening. They obviously do a pretty extensive psychosocial history. Oftentimes what we see in those cases is that detail in regards to what happens prenatally in regards to exposure, we don't get that information until there's been a strong relationship developed with the family, 3 months in, and then they start talking. So then we would try to identify if there are additional services needed or additional evaluations. But our experience has been when someone walks into a juvenile justice door, they're pretty cautious about all the information that they share, especially the families do, which is totally understandable. I mean, because, this is a court and a judge and, probation. But I do think you're right that that's something we need to be more sensitive to, and not just fetal alcohol, but also, we have kids that are exposed to other substances prenatally that are of concern. They don't have as clear symptomatology that's kind of been outlined for FAS, but I think we should be more careful of that, and I'll talk to our assessor about that. That's a good idea. Any other questions for any of the programs?
Hi. My question is for Bear Cares. So you mentioned that you have the capacity for 250 referrals, and out of those, if I understood it correctly, out of those 250, 18% is Head Start. Your other referrals, where would they come from?
The other referral, am I on?
Yes, you're on.
The other whoa, there we go. Let's try that again. The other referrals can come from other school districts within the county. It's not impossible that they could come from other child care centers. So wherever the young child can be served, would be possible for a referral to come from them. Referrals can be made by family members, by parents, by physicians, fortunately not by the criminal justice system yet our whole goal is to put you all out of business. So the referrals can come from many different people that are involved with the child and from other school districts or child care centers within Bexar County.
You also mentioned partnerships, that you're looking at building partnerships with other agencies. Can you speak a little bit about that process of partnering with us?
You want to start on that?
Well, this is kind of where Bear Cares is kind of in that, we're working on that, I guess is the best thing to say, really. Right now, those MOUs are being developed, and we're reaching out to a lot of different agencies right now to really start working on that. And just to kind of add, we want to serve a community. You know, we don't want to target just one specific where we're getting referral from. We want any provider to know that if they have a child that comes into the doctor's office just to see the pediatrician and mom and dad are saying, I think my kid has ADHD, I think maybe there's autism going on here, that they can be referred to Bear Cares, and Bear Cares becomes that one-stop shop for our community. That then, therefore, they can come there, we have the resources then that can send them out. Now, that's the goal. We're not there yet, but that's what we're working towards.
One thing I will say is that in terms of referrals, Bear Cares, and other information, in your flash drive, even though we didn't have it up on the screen, there is some more information. There's a PowerPoint that Leanne provided as some backdrop to understanding Bear Cares and system of care, and that's on your flash drive. So you can learn more and go to the website, and more will be there about how to become a partner and what your partners are looking for. And there was a question right back here, yes.
Yes. Good afternoon, everyone. This is for Dr. Very Austin. So with such small numbers in the program, how are you prioritizing who can take part in your program?
Well, it just really depends. We have the initial screening and the staffings. The head of our intensive clinical services department of our probation unit kind of reviews all the cases on a daily basis of who got arrested last night, what was there's a test we use called the MAZY that they evaluate what their criminogenic need is, if it's a moderate level of care that they'll need. And so we kind of pick from that list that hits those points. Probably every week there might be 3 or 4 names that meet those, and then we'll check and see some of those kids may have already committed a heavier crime that they're not eligible, because we don't want to mix the more criminogenic kids with the kids that are just have mental health. The kids that don't have a real involved family member, we can't take them either. So I was really surprised, because that list over the course of a month has probably 30 some names on it. So early on this year in April and May, I was getting lists and I thought, oh my gosh, we have so many kids that we're going to be able to help. And then it got to be August and we're trying to figure out which one's on the list, but none of them fit for the first month, because maybe they had assaulted their family so they got diverted into the family enrichment court, or maybe they have a history of labor or sexual trafficking, so they got diverted to the restore court. Because thank goodness we have as many programs as we do that really can help everybody. So they weren't considered the best fit for the first time boys mental health court. Does that help answer your question? Okay, very good.
So we don't want the community referring kids, just saying.
We do.
Refer them to us at 3, and we'll try to prevent them.
I always have mixed feelings about bringing up stuff that we do in juvenile justice. If they're in our system, we will work, and I'm not trying to be mean, but that's the last thing we want, is for someone to go, well, you know what, if you press a charge, I hear there's really good services in juvenile probation. We don't, because if you have any questions, if there's a kid that you're struggling with, contact us and we can try to get you connected to certain agencies that we know in the community. We do not want a kid in our system who doesn't need to be in our system.
Let me add to that just a minute. Although we were talking about the newness of this current piece of Bear Cares targeting the youngest children in our community, Reach out to Bear Cares if you have older children that you believe need assistance in mental health issues or families before they get to the courts. I mean, it's not impossible for a 7-year-old or an 8-year-old or a 9-year-old or a 12-year-old not to have yet gotten into trouble, but reach out. You know, go ahead and make a referral to Bear Cares, make a referral to CHCS, go to your school and ask for a referral. If all else fails, call Head Start. I mean, granted, we only serve little kids, but we'd be very happy to share resources and guide you in a direction if you know of people that have elementary age, middle school age, even high school age children prior to their getting into the juvenile justice system, that we can provide them the mental health services and support that they and their family needs.
Yes, sir.
Follow-up to that, I recently had a teen who was getting ready to age out, turning teen. So he was 17, clearly had mental issues. What's the relief for somebody in that state? Is there anything that we can refer him to?
So, I see Leanne back there. So just so that everyone here knows, if a child first commits an offense at the age of 17, that's an adult in the state of Texas. So they go straight to the adult system, sit in the adult jail with all that stuff. Although we try to help the jail and hold them in our system, but they're technically in the adult system. So that is this really tough age right now. And it's a really difficult age because if they commit a crime, they're considered an adult, but yet they still need a parental consent for treatment. There is a new, do you want to mention it a bit, ma'am, about the psychosis program, or is it not at announcement stage yet? Did I just blow it?
So the local mental health authority here in San Antonio is the Center for Healthcare Services, and so we provide services and supports to individuals. We have an ECI program, the 0 to 3. We have Bear Cares. We have children's outpatient that goes up to 17. Yes waiver up to 19. And then we have our adult services. And so one of the things that the state of Texas has implemented is a new early onset psychosis program, and they will start serving this month, in October. We're set to have, I think the training will be the 12th, 13th, and 14th. For the specific curricula that they'll be using, but they're focused on individuals who are age 14 to age 30 that have a psychotic disorder of some type diagnosed within the last 2 years. And so it has to be, so we're looking at getting that early onset psychosis. And so we'll be taking referrals for that program in the next probably 2 to 3 weeks. And so if you have kids that have recently been diagnosed, or young adults that have recently been diagnosed with some kind of either a psychotic disorder or bipolar or major depression with psychosis, then they will be possibly qualify for that program. And it's a pretty intensive program itself. It will be a small pilot. The state of Texas has 8 sites around the state that will be piloting it, and so Bear County is always a great place, as we talked about earlier, about piloting new programs. So we look forward to that. If you have a child or an adolescent that you're working with that has a mental health need, you can always reach out to CHCS, and they can do a screening and assessment for needs. And so that's kind of some of the stuff coming out.
And you're on camera. You're welcome. Any other questions? Thank you so much. This is a large
Thank
group.
you.
We really appreciate that because we know the other seminars.
It is an eventuality.
Very good. Thank you for